Welcome back to the Deep Dive, where we take complex, high-stakes information and distill it down into the core knowledge you need. Today, we are strapping in for a really critical mission, mastering the protocols of advanced cardiovascular life support. When you're operating in an emergency environment, you simply don't have time to second-guess yourself. You need these evidence-based responses instantly accessible, especially, when the clock is counting down.
That's exactly right. And if you're a medical professional, a young learner, or maybe someone who creates educational content in this field, you know that ACLS is really the backbone of modern resuscitation. Our mission today is to give you a comprehensive, scientifically clear, and thorough summary of that core framework, the systematic, evidence-based responses designed to get the absolute best possible outcome.
And our source material for this is based on their robust 2015 AHA guidelines, which established some really pivotal changes. But before we get to the advanced stuff, we always have to start at the beginning. Scene safety. It's paramount. Once the scene is safe, we make a quick clinical assessment. Are they conscious or unconscious?
That initial decision is everything. I mean, if the individual is unconscious, we initiate the basic life support, or BLS, survey immediately. If they're conscious, we pivot to the ACLS survey, which uses that systematic ABCD approach.
Okay, so let's focus first on that foundation, BLS. We know that the circumstances of cardiac arrest are profoundly different based on age, which is why we have two distinct chains of survival.
Precisely. The adult chain is built around, quick recognition, activating EMS, then early CPR, defibrillation, ACLS, and finally post-cardiac arrest care. It's really focused on a sudden electrical problem.
But the pediatric chain, that one starts earlier.
It does, and this is a crucial distinction. Since emergencies in children and infants are, they're most often triggered by breathing problems or shock, the pediatric chain begins with prevention.
Prevention. So you're trying to stop the arrest before it even happens.
Exactly. You prevent it, then early CPR, activate EMS, advanced life support, and then post-cardiac arrest care. Prevention is absolutely the first link.
And when we talk about the mechanics of CPR, the biggest philosophical shift, really, confirmed in those 2015 guidelines, was moving away from the old ABC sequence. We now prioritize CB.
That's compressions airway breathing. And that change wasn't arbitrary. The evidence just showed that delaying chest compressions, even for a few seconds to check the airway, it resulted in a significant loss of critical perfusion. We have to get blood moving now.
And as part of that simplification, that emphasis on immediate compression, we no longer recommend the look, listen, and feel technique for breathing.
Correct. I mean, if the person isn't breathing normally or is only having those agonal gasps, you just skip that delay and start compressions immediately.
This brings us to the core concept of high-quality CPR, because arbitrary compressions don't save lives. Precise quantitative compressions do. So what are those non-negotiable metrics we have to internalize?
Okay, so the parameters are extremely specific. First, the rate. 100 to 120 compressions per minute. We know that compressing faster than 120 actually reduces the time the heart has to refill.
So faster isn't always better.
Absolutely not. It compromises perfusion. Next is depth. For adults, it has to be 2 to 2.4 inches, or about 5 to 6 centimeters.
Right.
And the third requirement, one that's often overlooked, is allowing for full chest wall recoil between every single compression. That recoil creates a negative pressure that draws blood back in. No recoil, no refill.
And the whole time, the relentless focus is on minimizing interruptions, isn't it?
It is paramount. Even for rhythm checks or charging the defibrillator, those pauses have to be as short as humanly possible. And if you're going to check for a pulse, you must limit that check to no more than 10 seconds. Any longer, and you are actively hurting the chances of survival.
Okay, so what about ventilation ratios? Without an advanced airway, it's still the classic 30 compressions to 2 breaths. But how does that change once we secure an airway?
Well, once an advanced airway like an endotracheal tube is in, compressions become continuous. You just keep going. And you deliver 1 breath every 6 seconds, so you're aiming for about 10 to 12 breaths per minute.
And it's important not to overventilate.
Crucially important. Excessive breaths increase the pressure inside the chest, which actually reduces the blood flow back to the heart.
That makes perfect sense. Okay, let's transition from BLS to the 4 pillars of the ACLS survey: airway, breathing, circulation, and differential diagnosis. Starting with A, airway.
The initial decision here is really strategic. You have to weigh the benefit of placing an advanced airway against the risk of pausing CPR. For immediate basic adjuncts, we use 2 main tools: The oropharyngeal airway, the OPA, is only for unresponsive individuals with no cough or gag reflex.
Because if they have that reflex, they could vomit and aspirate.
Exactly, and that's where the nasopharyngeal airway, or NPA, can come in. It can often be used in conscious or semi-conscious individuals, but you have to avoid it if there are severe facial fractures.
And suctioning.
Any suction attempt should not exceed 10 seconds, and you must follow it immediately with 100% oxygen to prevent hypoxemia.
Moving to B, breathing. We start with 100% O2, but the goal is to titrate that down to a saturation of 94% or greater. This is where quantitative waveform capnography really shines, doesn't it?
It's the true measure of CPR quality. It gives us real-time data on perfusion by measuring the end-tidal CO2, or ETCO2. High-quality CPR should give you a reading between 10 to 20 mmHg.
And if we're consistently failing to hit that number, what is that telling us?
It's a very bad sign. The ETCO2 is persistently less than 10 mmHg after 20 minutes of CPR, especially in an intubated patient. It strongly suggests you have insufficient perfusion. It often prompts the team to seriously consider stopping resuscitation efforts.
A powerful predictive metric.
Okay, on to C, circulation. We need vascular access for drugs. Foley is preferred, but if that fails, what's the next best route? The clear preference is the intraosseous, or IO route. We know from data that giving drugs to the ET tube is just highly unpredictable and unreliable. IO access gives you a non-collapsible route right into the vascular system.
And if we do get a peripheral IV in, there's a specific technique to get the drug to the heart, right?
Yes. Any drug given peripherally has to be pushed as a bolus, immediately followed by a 20 ml saline flush, and then you elevate the extremity for 10 to 20 seconds. This is how we use good CPR to circulate those meds. Without it, the drugs just sit there.
Finally, we reach D, differential diagnosis. This is where we stop just following the algorithm and start treating the cause, right? The H's and T's.
This systematic review is non-negotiable. The H's are hypovolemia, hypoxia, H+, which is acidosis, hyperkalemia, and hypothermia. The T's are tension pneumothorax, tamponade, toxins, thrombosis coronary or pulmonary, and trauma.
And of all of those, which two H's are the most common and often easiest to reverse?
It's hypovolemia, lack of volume, and hypoxia, lack of oxygen. Those are consistently the two most common and most easily reversible causes, especially for pulseless electrical activity.
Okay, let's pivot to the electrical shock itself, defibrillation. So for anyone creating content on this, what are the specific energy doses you have to cite?
For monophasic defibrillators, the dose is standardized, 360 joules for every shock. For biphasic, which are more common, you follow the manufacturer's recommendation, usually 120 to 200 joules for the first shock.
And the most critical action immediately after the shock.
Resume CPR. You start with chest compressions immediately and continue for 2 full minutes before you even think about reassessing the rhythm. You do not pause to check the pulse right after the shock.
Got it. Now to the pharmacological tools. Let's start with the standard vasopressor during cardiac arrest. Epinephrine.
The standard dose is 1.0 milligram of V, or IO, given every 3 to 5 minutes. And while things like high-dose epi and even vasopressin were explored, large-scale studies confirmed neither showed a superior survival benefit. So the standard 1 milligram dose is a routine recommendation.
That's a really important clarification. What about drugs for specific tachyarrhythmias, like a narrow QRS tachycardia?
For something like PSVT, we use adenosine. This drug has to be delivered as an extremely rapid IV push, followed immediately by a saline bolus. It acts fast, and you should warn patients they might feel some flushing or chest heaviness.
And for the more chaotic rhythms, like VF and pulseless VT?
For those, our primary antiarrhythmic is amiodarone. That's a 300 milligram bolus with a potential repeat dose of 150. Lidocaine is an acceptable alternative. And it's important to remember amiodarone has a really long half-life, sometimes up to 40 days.
And atropine. I know its role has been significantly narrowed.
It has. Atropine is still the initial drug for symptomatic bradycardia, a slow heart rate. But a major update is its removal from the standard cardiac arrest algorithm. It is no longer recommended for routine use in PEA or asystole. The evidence just didn't support a benefit there.
That clarifies things a lot. So now we can formally organize the arrest rhythms into 2 groups. Shockable versus non-shockable.
Exactly. The shockable rhythms are ventricular fibrillation, or VF, which is just chaotic, disorganized electrical activity, and pulseless ventricular tachycardia, or VT. With pulseless VT, the heart is beating so fast it doesn't have time to refill. The management for both is the same: CPR and immediate defibrillation.
And then we have the non-shockable rhythms, PEA and asystole.
For asystole, the flatline, your first step is always verification. You have to check your leads, check the gain on the monitor, Make sure you're not treating equipment failure. PEA is any organized waveform on the monitor, other than VF or VT, in a patient who has no pulse.
And since we can't shock these, the management shifts entirely to finding the cause, to the H's and T's.
That's it. For PEA and asystole, it's all about continuous CPR and aggressively hunting for and treating those reversible causes. Like we said, if you can fix the hypovolemia or the hypoxia, you might get the patient back.
Beyond the arrest itself, the source material focuses heavily on the broader organization of care. There's been a big shift away from just having cardiac arrest teams to using rapid response teams, or RRTs.
This represents a huge systemic change. RRTs were created because we realized outcomes are so much better when we intervene before the cardiac arrest happens. These teams were activated by early alert criteria: labored breathing, heart rate extremes, hypotension, altered mental status. They catch the deterioration early.
That preventative idea is key. Now, once you do achieve ROSC, return of spontaneous circulation, post-cardiac arrest care is critical. Let's talk about temperature and blood pressure.
Post-resuscitation care is just as critical as the resuscitation itself. The key intervention here is therapeutic hypothermia. It's the only documented intervention that enhances brain recovery in comatose survivors. You cool a patient to a core temp between about 32 to 36 degrees Celsius and keep them there for at least 24 hours.
So you cool the body to protect the brain. What about blood pressure?
Hemodynamically, the priority is maintaining a systolic blood pressure of 90 or greater, or MAT of 65 or greater. You strain with fluids. If that doesn't work, you escalate to vasopressors like epinephrine, dopamine, or norepinephrine. And if you suspect a cardiac cause, PCI stenting is preferred over clot busters.
Okay, let's move to the two specialized time-dependent systems of care: acute coronary syndrome and acute stroke. Starting with ACS.
Right. ACS covers everything from unstable angina to a full-blown heart attack or STEMI. It's so important to recognize that atypical presentations are common, especially in women and individuals with diabetes.
And the goal is always rapid reperfusion, right?
Always. For PCI, the door-to-balloon time goal is less than 90 minutes. If you're using fibrinolysis, the door-to-needle time goal is less than 30 minutes. Time is muscle.
The initial treatment uses the acronym MONA.
Morphine, oxygen, nitroglycerin, and aspirin. But, and this is a critical caution, nitroglycerin is absolutely contraindicated if the systolic blood pressure is less than 90. It's also contraindicated if the patient has recently taken a phosphodiesterase inhibitor like Viagra in the last 24 hours. You risk profound hypotension.
Good. Finally, acute stroke care. This is all about rapid imaging and diagnosis.
It is. Ischemic strokes from a clot are 87% of cases. Hemorrhagic from a bleed are 13%. The treatments are opposites. So the single most critical piece of data is the time last seen normal. That determines eligibility for the clot-busting drug TPA.
The mantra is time is brain, and the ED is driven by very specific time goals, the NIND's goals.
These are the markers of high-performance stroke centers. From ED arrival, general assessment within 10 minutes, CT scan completed within 25 minutes, CT scan read within 45 minutes, and the administration of fibrinolytic therapy must happen within 60 minutes.
That is a blistering pace, but it's the difference between recovery and permanent disability. And are there CT findings that would rule out thrombolytics?
Yes. The therapy is excluded if the CT shows a large established stroke, which means multilobar infarction, or more than 1/3 of a cerebral hemisphere is involved. You're looking for that sweet spot where the benefit outweighs the risk.
This has been an incredibly comprehensive review, taking us from the first BLS assessment right through advanced drugs and post-resuscitation care. The importance of clear, systematic action, CAB, ABCD, the H's and T's, it just can't be overstated.
And you have to remember that this systematic approach is entirely supported by effective teamwork and knowing these protocols cold.
To make sure you've locked in those critical timing requirements we just discussed, here's a quick review exercise for you. Based on the NIND's time goals from ED arrival, what are those 4 specific time goals for general assessment, CT scan completion, CT read, and fibrinolytic administration? Think about those minute markers.
And, the source material reminds us that survival rates improve not just by having sound protocols, but by performance improvement. And so the final, crucial step, and one that's often overlooked, is the post-resuscitation debriefing, focusing on analyzing performance to identify what can be done better next time. That continuous cycle of learning is how the best outcomes are truly achieved.